Greetings. I'm Paula Cunningham, State Director for AARP Michigan. To those of you who have been watching this Ask the Doctor series all along and have watched every 4-part series, we say thank you. To those of you who are tuning in for the very first time, you can always go back and watch the series on a variety of channels, but we say thank you for joining us today. And a very special shout out to all of our panelists and participants who participated in this Ask the Doctor series. We're now asking you to let us know what you'd like to hear from us. What other topics of interest would you like to have us present to you now or sometime in the future? Just put it in the chat. AARP is so flexible, and we are involved with caregiving and fraud and Social Security and all sorts of wonderful things that will help to improve your life, the life of those that you love. But a very special thank you today to our one and only Dr. Octavia Cannon, who is a board certified physician. She is a member of the Alliance Obstetrics and Gynecology group, and she is also an honors graduate student from Johnson C. Smith University, where she was a Duke and UNCF scholar, honors scholar. And she is absolutely phenomenal and is the former past president of the American College of Osteopathic Obstetricians and Gynecologists. And she was the first woman in their 84-year history. So as we conclude this program out, a big special thank you to you, Dr. Cannon, and thank you to all of you for watching. Please stay tuned now for Dr. Cannon and Ask the Doctor.
Good day and welcome. This is our fourth and last segment of the Ask the Doc series, and we welcome you today. We're so excited to see you again, and thank you for giving us a little bit of your time. If you have any questions during this program today, please share them in the comment section and I will try to address them and get them answered live for you. Today's subject, again, is Gotta Go Right Now, a talk and a conversation about urinary incontinence for men and women. So if you have to step out or you have to go away from the actual live chat, we have it recorded. It will be available on our AARP of Michigan Facebook page and also on YouTube. So if you can go back or you can invite your friends to watch back as well. So the last thing I'll say before we get started is that for those of you who have been on the previous times, you know that we are not providing personal medical advice during this program. But if the conversation sparks interest in your personal health or the health of people that you love, we strongly encourage you to follow up with your primary care providers. So I am excited to have two guests today, Dr. Jamie Bartley and Ann McCauley. Let's start with an introduction of Dr. Jamie Bartley. Dr. Bartley currently practices at Sparrow Medical Group Urology in Lansing, Michigan. She earned her Doctor of Osteopathic Medicine degree from MSU College of Osteopathic Medicine and completed her urologic surgery residency with MSU College of Osteopathic Medicine, Metro Detroit Urology Program in 2012. She then pursued fellowship training in female pelvic medicine and reconstructive surgery at William Beaumont Hospital. Dr. Bartley has an interest in pelvic floor health, including female and male urinary incontinence, pelvic organ prolapse, robotic surgery, kidney stones, and other areas of general urology. Dr. Bartley is on faculty at MSU College of Human Medicine and the Sparrow Urology Department as a clinical instructor for students and residents. She is very valued, admired, and respected, and she works hard. She has nearly 20 peer-reviewed publications as a first author or co-author and has presented at several national and local meetings. She has also received many awards for her clinical and academic excellence. Welcome, Dr. Bartley. We appreciate your time and your expertise today, and thanks for joining us.
Thank you. Thank you, Dr. Cannon, and for AARP for bringing us on. This is such an important topic and something that we don't often discuss in, real life or in, because it's kind of embarrassing, and a lot of patients have a lot of difficulty bringing up issues with this. So one thing I really want to encourage, and I think we have some slides to kind of go over, if we can load those up, just as a quick kind of overview about what we're going to talk about and what we're hopefully going to answer questions for today with everyone. So we can just move to the next slide. So I just have a brief kind of overview of urinary incontinence, and that's going to be kind of our main focus today. And what is incontinence? It's kind of one of those big doctor words, but basically it just means loss or leakage of urine from the bladder. And this can vary from a slight loss of urine to complete inability to control urination. And you can imagine there's a big spectrum as to the severity of this. So go to the next slide. So this can have a huge negative impact on all aspects of quality of life. So we always say that it's not a life-threatening condition, but it's certainly life-altering, and it can be associated with mental health disorders. It can lead to depression, emotional disturbance, and it importantly can really isolate people from their family members and from events that they really would otherwise enjoy doing. So next slide. So I'm a urologist. We take care of the urinary tract. So that includes the kidneys, the ureters, and the bladder. A lot of people think of urologists as just a prostate cancer docs, but we do a lot more than that. And I specifically focus on the whole pelvic floor and pelvic health area, which includes a lot of the bladder. And again, we do men and women. So next slide. So just a quick review of normal urinary function. So the main job of our bladder is to store the urine. Only a few times a day should we get a warning and have it be full enough that we're actually going to empty our bladder. The urine exits the urethra. The urethra is surrounded by some pelvic floor muscles that work as a urinary sphincter. And these sphincter muscles should be strong and they should hold the urine in the bladder. Only when the muscles relax and the bladder squeezes, and this should be somewhat voluntarily, are we going to empty our bladder. So next slide. We're going to kind of focus on two reasons for urine leakage today. And these are the main reasons that patients have leakage issues. The first one is what we call an overactive bladder. And this is associated with the sudden urge to go to the bathroom. Also, we see increase in frequency of urination, both day and night. And when you have leakage, we call that urge incontinence. Sometimes you can have an overactive bladder and not have leakage. And sometimes you have an overactive bladder and will have accidents and leakage. And this, if you want to think of it as like the pump being too strong. So the bladder doesn't want to hold it. The pump is constantly going and trying to empty. So we can go to the next slide. So again, this is associated with urgency, frequency, and then nighttime. And nighttime is particularly disruptive for getting a good night's sleep, which we know is very important for making us feel good and be able to function throughout the next day. So next slide. The next reason of leakage is what we call stress incontinence. And I think of this as kind of having a weak valve. So if we think about that valve kind of on the bottom where the yellow arrow is, that sphincter muscle has weakened. And these are leaks that happen with cough, sneeze, laugh, exercise type activities, bending, lifting, pulling. And that is, again, due to weakness of the pelvic floor and urinary sphincter muscles. So next slide. Things that can put patients at risk of this are vaginal deliveries, so pregnancy, delivery, even C-section, although we think that they may be somewhat protective. Other issues like chronic coughing or straining, obesity can be a risk factor. And, just being a woman, and for men as well, they can have issues with this as well. So next page. Speaking of men, men don't have stress incontinence quite as often as women. And there was a question already from a male viewer where he asked that, what type of issues do we have for men? And we'll talk about that as well. But men don't have stress incontinence as much, and that's usually because they have a prostate and a longer urethra. But they certainly do have and can have issues with an overactive bladder. So next page. In men with stress incontinence, we usually see that associated with men who've had prostate cancer surgery. And so typically it's a result of the disruption of the normal continence mechanism. And that's going to be a little bit trickier. And you certainly need to see a urologist or a specialist if that's part of your history. And so just kind of a quick overview. I know that was really rapid fire, but hopefully that gives you a good idea about what types of things we want to focus and try to help answer some questions today. And again, it's not life threatening, but it can certainly be life altering, life limiting, and we don't want to ignore it. I also want to emphasize that it's not a normal part of aging. It can be common, but it doesn't mean it's normal. And it definitely doesn't mean that there aren't things that we can offer to help improve your symptoms and your quality of life. So we hope to be able to do that today. And thanks so much for joining. So
that is fantastic. Thanks, Doc. I know that was really, really fast. And thank you so much for giving us that concise yet thorough introduction into what you do as a urologist every day. And I just wanted to mention, we have viewers from not just from Michigan, but from North Carolina, Pennsylvania, New York, Maryland, all over the US. So again, if this is something that is ringing bells with you or sparking some interest, then definitely see your primary care provider so that you can get your issues addressed. I'm seeing actually viewers from Alaska and California as well. This is fantastic. Spread the word. So we really just want the goal of AARP of Michigan and AARP overall is wellness of all of us as we continue to be seasoned in age. So I'd like to go right into introducing our second guest speaker today, Ann McCauley. She is a pelvic health physical therapist at Sparrow Outpatient Rehabilitation in Lansing, Michigan. She graduated from Michigan State University with a bachelor's degree in kinesiology in 2001, and then earned her Master of Science degree in physical therapy from Grand Valley State University in 2005. Ann has been a physical therapist for 18 years and has been treating pelvic floor conditions for 15 of those years. She treats both men and women with a wide variety of pelvic health diagnoses, including both urinary and fecal incontinence, pelvic pain, abdominal pain, gastrointestinal and evacuation disorders. So if you're having issues with bowel movements, constipation, or diarrhea. The post-surgical patient is another one of her specialties, along with the oncology or cancer patient. Welcome, Ann McCauley.
Hello.
Thank you for taking the time out of your busy schedule to join us today. I just want to start off by asking you, what can a patient expect on their very first visit with you?
Okay, yeah. Thank you for having me. It's such an honor to be here. It's really exciting to hear the representation throughout the states. This is awesome. So so when someone comes to see me for physical therapy, typically they're referred by either their primary doctor or someone like a urologist like Dr. Bartley, maybe their OBGYN, like Dr. Cannon. Really need a physician referral, and depending on the state, but you might want to check in with your physician, check in with your urologist first, and then you might get referred to physical therapy for pelvic health rehabilitation. So typically the first time someone comes in, it's a lot of education. We just sit down with the patient. We take an hour just to talk about the history, where things have been, what they used to be like, if it's something new. Some people have struggled their whole life. Sometimes it's something that's just more recent, maybe the past 6 months to a year. So really each patient is individual. So we do a big history, but we also really like to do a lot of education in physical therapy. We do trying to help people understand their pelvic floor muscles. And that's just something that is really hard for a lot of people to wrap their head around, because it's something typically before you ever are incontinent, it's something you never really had to think about, because they were just working. You were just, pooping and peeing, living life was good, and you never really had to think about it. Then when things start to become dysfunctional, suddenly you need to understand those muscles better and how do those muscles contribute to your problem. So we do a lot of education, including showing a pelvic health model. I actually have one here I was going to just show briefly if I have the time.
Yes, please do.
Yeah, so I can actually just show that right now. This is something, and the reason I brought this in here was because most patients find this really helpful to just see the anatomy. Part of the thing about the pelvic floor is it's, I'll hold up here in a second, is that it's something we can't see, and we can't see any of our muscles. But I explain to patients that really, like our bicep, for example, this muscle here, our arm muscle, we can see it moving, bending, and straightening. We can surmise that there's some activity because we use a lot of visualization for movement, whether we can appreciate that or not. The pelvic floor is deep to so many muscles, and so the deep to other layers of the muscles. So to be able to see a model can be really helpful. So this is a female model. I do have a male model too. I know there's some male viewers, but I'll just show this one first. So this is a pelvic model. So this is our bony pelvis. And then this, I'm going to flip it up. And this is actually our pelvic floor muscles. I'm trying to get the right view here. So everything in red really is your pelvic floor. And this is, if you've heard of the term Kegels are synonymous to pelvic floor muscles. So physician Arnold Kegel kind of discovered or identified the function of these muscles. So he kind of got his name coined after them. That's why you may often hear the term Kegels for pelvic floor muscles or pelvic floor muscle contraction. So anyway, this is kind of showing your pelvic model. I'm trying to get my camera right here. So this would be a female model again. So this is a rectal opening. Here is the vaginal opening and the urethral opening. And then, I'm sorry, my camera.
So it's perfect. We can
is
see
it okay? Can you see it okay?
Yes.
Okay, so I'm just normally have this like right in person. So labia would be here, buttocks are here. These are our sit bones right here, these bony bones right here. Back in the back, you can kind of see this. You can see how widespread it is. Here's your sacrum and tailbone. Your back would be here. So these are the wings of your pelvis. So this is just kind of really helping you to see how far reaching this pelvic floor is. Really, it goes from sit bone to sit bone, from your pubic bone in the front all the way to the tailbone in the back. And I'm just going to take these organs out for a second and kind of show you this too. So this is kind of showing the inside of the pelvic floor. My lighting isn't the best here. These are arteries. So just kind of showing this big bowl of muscles that really kind of wings out from side to side and really helps you to appreciate everything in red there. All these different muscles, they have different names, but collectively when you do a Kegel or a pelvic floor muscle contract and relax of these muscles actively, you're actually engaging all of these muscles. They should all contract together. They should all relax together. They should. And so that's one of our goals in here and subsequent visits is to try to understand, is that the case for you? How are your muscles functioning? So we do typically a pelvic floor muscle assessment, which is actually a digital assessment. So internal exam. So it's not like at the gynecology office when you go in and have a speculum exam or in the stirrups. It's really just a digital exam. We use a glove, a little bit of lubrication, and we have you squeeze and relax. We're just trying to assess all the different layers of the muscles. How are they functioning? Are they coordinating well? And that's one big thing we're really trying to understand in here is, are you able to squeeze, but are you able to relax these muscles too? It's not just about tightening. It's really, in here we kind of almost don't use the term strength as much as coordination of these muscles because they need to be operating with all of our bending, moving, coughing, lifting. And like Dr. Bartley was talking about, how are these muscles working with those functions? And then again, we talk about how to coordinate that for bladder retraining and urge suppression and things like that.
Yeah. So I got a quick comment, if I can just add something here. Is that okay, Dr. Cannon?
Absolutely.
So I'm a urologist. I went through 6 years of residency. I never heard of pelvic floor therapy for urinary issues my whole time.
Wow.
So you can imagine patients are they're not even aware that this is a possibility. And then I did fellowship and I learned all about it. And I moved my practice to Lansing about 5 years ago. Anne and her partner were one of the first people that I insisted on meeting when I moved practices here. These therapists are like magicians. I mean, yes. So many patients have no idea that you can just restore normal bladder and bowel function with a physical therapist, and you don't need medications or surgery. You can go and you can learn, and people are like, what? I never knew that existed. Well, of course not. I didn't know it existed, and I went through training. So I think this is I think this is a huge takeaway from this is ask your doctor about physical therapy. And, they're not in all areas. And so you do want to make sure that you have someone that knows what they're doing. Sometimes Kegels can be counterproductive, and so you have to definitely know. But just to encourage you, if you don't want to take a medicine or have a surgery,
Mhm.
physical therapy can be a great option for a lot of these issues. So
Completely agree with that. I think that's awesome. I was going to say the same thing, Doc, because you see it a lot with women who have just had babies, or even as say they're carrying twins or triplets. That all of that pressure on their pelvic floor really can affect their muscles, and we see
Mhm.
them at their 6-week visit, and they're or even before that, because they're worried about the things that are happening. I think
Mhm.
pelvic floor therapy or physical therapy in general is a wonderful way to allow your body's natural functions to heal you. Another
Mhm.
aspect of osteopathic medicine, Dr.
Mhm.
Bartley, as you well know,
Mhm.
and also to allow you to have options. Not if you don't
Mhm.
want to take medication, or say you are taking medication for other things and it might interfere with the medication that you're currently on. If you just want a better approach, or and I shouldn't say better, but I mean something better for you. I think that
Mhm.
many
Mhm.
times physical therapy and overall medical treatment involves more than one thing. And that's the
Mhm.
conversation you should have with your primary care provider. Go in there with questions written down so that, number one, so you don't forget that, something you thought about for weeks, and then you get in there and you get kind of anxious and nervous, or you start getting off talking about something else and you forget. Write down a few questions, and that way you know that the time is utilized quickly, because those visits can be quick and you will really get some use out of them. I see a
Mhm.
question from Ms. Desiree. I don't have health insurance right now due to contract work. I do Kegel exercises. Are there other alternatives to help with these issues? I assume she means other besides Kegels. So, Anne, I think I'll ask you that question.
Well, yeah, I definitely, I just kind of to piggyback what Dr. Bartley and Dr. Cannon said too, is, finding that kind of team approach is ideal. And not every region in the States you're going to find that necessarily. So asking those questions and when you do see your physician, but I know this question is regarding not having insurance, maybe not having a primary care provider. I will say, there are some good things about social media, this being one of them. And then there's actually a lot of good things online. Too nowadays on YouTube. There's some great, physical therapists even, or some other, maybe Dr. Bartley, you have some tips or for where to search, online. But Sarah Duvall is a physical therapist that does a lot of great talks, little tidbits on YouTube. If I'll think of a few others that come to me, but I love her because she's very concise and she can give you some direction. A lot of this, you can learn on, getting the right information. But if you feel like you're getting to the end of the road and you feel like, I'm doing everything I can, I've tried this, I've tried that, I'm not getting anywhere. Sometimes it's just, you just need maybe one or two consults with maybe even a physical therapist, a urologist, but it's always good to get things cleared with your primary care, with your urologist first. Maybe even some hospital systems might even have some financial aid to give you an appointment or two if you don't have the insurance. So reach out to the local hospital and say, hey, I don't have insurance. Is there any financial aid where I could see somebody even for a couple of visits and maybe get a referral? Some therapists even do some pro bono work. You could call around town. There will be some websites that I know are going to be cycling through about where you can get online and search for a physical therapist, maybe even just talking to one on the phone. They might be able to give you some direction that way.
Yeah, I was going to mention asking about payment plans with a particular office to
Yeah.
see if they offer them. They may say no, but if you don't ask, you won't find that out.
Yeah.
And you are right. I think both you and Dr. Bartley provided some links for the audience to go and to look into more information about all of the things that we are discussing today. Dr. Bartley, anything else you want to add about that before we move to the next question?
I know right now there's some companies that are working on like some home pelvic floor exercise devices. I think Innovo, it's INNOVO. It's like a physical therapy kind of belt thing. So that can be a good starting point. Most of these are going to be cash pay, and some can be quite expensive. I don't think they are better than a good pelvic floor therapist, but that could be another option. I love YouTube. I think there's some good resources if you just kind of Google pelvic floor therapy exercises. especially for things like incontinence and urgency, frequency, overactive bladder. If you have like pelvic pain issues or, bleeding or UTIs or things like that, those are going to need a more specialized approach. But if you're kind of just working on some incontinence issues, I think YouTube or the internet can be a great resource, or again, maybe some of these like pelvic floor home exercise type devices that are out there and available. So
there's a question from Mary that we kind of actually delved into a little bit, but I wanted to recognize her comment. Are all physical therapies specialized in pelvic floor therapy? I think the answer is no. But how do you find one who is? It may take a little bit of research, but I think all of these links and websites that we're providing are helpful.
And isn't there a website where like most of the pelvic floor therapists are, you can put your zip code in or your location and they'll have the people that are especially certified in pelvic floor therapy?
Yes. And I think they're provided, that's kind of scanning through on the bottom, but that's a very good question. And you're right. You want someone that has gone through some series of training. Herman and Wallace and the American Physical Therapy Association they were kind of together. They kind of broke tracks, but they really provide the same training. But you really want someone who has had some training. And in my opinion, someone that might be able to assess your muscles both externally and internally, because these muscles are so deep, and really to really understand them, to have the right assessment and assessment tools. So those websites will direct you to people that have been trained through those tracks. So,
and I think you both mentioned, but just to make sure that the audience is aware, you may have to have a pelvic exam. Even if you've already seen a doctor like Dr. Bartley, when you go to the physical therapist for pelvic floor therapy, a provider like Ann may have to do another pelvic exam. So I don't want you to be shocked or alarmed or thinking that something's inappropriate. This is part of your assessment. So just to give you that heads up. And Claire wants to know if there are any breathing exercises that help with incontinence.
Great question. We talk about breathing in here constantly. It's really tied in together. It's a kind of imperative to know that. So I'm glad you asked.
Yeah, we talk about breathing in OB as well.
Yeah, right. Right. Yes. I mean, I can learn a lot from you, I'm sure. And and how it relates to the pelvic floor, we talk about the diaphragm. If you're familiar with, basically, God forbid you were cut in half, on the bottom of your rib cage is your diaphragm. It's a dome muscle like this. So your pelvic floor, like I kind of showed you, is down here. As we breathe, ideally taking a deep breath. A lot of us aren't doing that very well. So learning how to take a quote unquote diaphragmatic or belly breath, big deep breath. If you take a deep breath in through your nose, your ribs should expand. Your diaphragm is going to come down. You're really getting air down into your lungs. When the diaphragm descends, the pelvic floor also descends like a piston. So it kind of works together. So when you inhale, the diaphragm comes down, the pelvic floor relaxes. Doesn't mean you're going to pee. It just means you're relaxing, right? Just like you're just relaxing any muscle. When you exhale, the diaphragm comes up and the pelvic floor comes up, meaning you can Kegel or squeeze along with that. So it's a really great way to coordinate your pelvic floor muscles with breathing. And so a lot of us are doing that wrong. If we've been pregnant, it's like babies are in there pushing up against the diaphragm and overstretch. Everything's kind of deconditioned and out of whack. So when we get out of delivery, a lot of times, we're just taking care of our baby. We're just going, and it could be years. I've seen people in their 90s that, they've struggled with this ever since, their childbirth or really pregnancy in and of itself is just, game changer with how we function. Then you're handed your baby, thank God we got a prize. But, at the end of the day, we're not really rehabbing ourselves. We're taking care of the baby. So sometimes that gets lost in the shuffle and we just kind of get to survival mode about how we operate. So in here, we're just trying to help people understand that. So that helps you coordinate your pelvic floor with breathing. Basically, when you squeeze and elevate that pelvic floor, exhale, breathe. Don't hold your breath because it's adding pressure downward pressure. But also with urgency, frequency, we also teach people when your bladder's, gotta go, just like this talk, is that the bladder is urgent. Our nervous system is ramped up during that time. And a lot of times if we feel urgency and if we've leaked before, it's ramped up even more because we've playing over our past failures. We've leaked on the way. We don't feel confident we're going to make it. It's very stressful. It's kind of like PTSD in that regard. So as you're doing that deep breathing, there's so much in breathing, not just the coordination with your muscles, but really it causes your nervous system to quiet and calm down. And it kind of that helps the bladder to just calm down, which is essentially it's relaxing. So the muscle's not tightening or squeezing, like Dr. Bartley was talking about that. where it wants to pump. I like that analogy, like where it just wants to push everything out. It doesn't like to stretch. So when it gets to a certain amount of fill or stretch where it feels noxious or it habitually will empty, our nervous system is going to ramp up and we're going to respond. If we've leaked even a drop, we're rushing. But as we're rushing, we're ramping up our nervous system. So just some of the things I teach people is it's very counterintuitive. It doesn't make sense until you kind of hear it this way, because your brain's already in the bathroom and you're just going to rush. But trying to sit and breathe, just do some breathing. Doing a few Kegels as you're exhaling is excellent too, because these pelvic floor Kegel muscles are attached neurologically also to the bladder. When they're squeezing, the bladder has to relax. It's a quieting tool. So the breathing gets the nervous system down, but also helps you do a Kegel well to further ammo back to the bladder. It's essentially your arm wrestling the bladder, getting the bladder to calm and quiet. So
it's interesting. Every session that we've had this month, stress has been the stronghold in every single one of them. So I hope that the audience is listening to that and practicing that self-care and trying to decrease the stress, in your life. Dr. Bartley, I've got several questions for you, and time is fleeting. The first one is from R. Kell and says, how often is hormone therapy helpful with incontinence?
Yeah, I saw that question come through and I was hoping you were going to ask that. That's such a great question. Oh, I could talk for hours on this, but I'll try to be very concise and leave it to about a minute. 20 years ago, a health study came up that scared everyone away from estrogen because of the maybe increased risk of breast cancer, heart disease, or stroke. So any woman that's over the age of 70 or around 65, 70 years old probably never went on hormone replacement, or if they did, they went on a very short amount of time. Systemic hormone symptoms, hot flashes, night sweats, those last on average about 7 years. Then they eventually go away. A lot of women suffer through them and, they don't want to get breast cancer or things like that, so they didn't take any. We know now that those studies were very flawed and that hormone therapy in general for the right patient can have a lot of benefits. And that's specifically talking about systemic hormone therapy. I'm going to focus more on vaginal hormone therapy because this is my area, and we actually have a semi-new term that we call the genital urinary syndrome of menopause. And this is the gift of menopause that keeps on giving. So these are all the changes that happen to the vaginal tissue, the pelvic floor muscles. The bladder and the urethra and the pelvic floor, they're right above the vaginal area. Those muscles and tissue are very reliant on estrogen in order to maintain good, healthy tissue quality. So collagen, lubrication, blood flow, even a healthy balance of the vaginal area is all related to a good amount of estrogen level in the system. And women didn't have any of that for many, many years after menopause. So what we see and what I see in my practice all the time is a lot of issues with vaginal dryness, vaginal thinning, itching, burning, UTI symptoms, urinary tract infections, and incontinence. And these are all related to the loss of estrogen to some extent, maybe not 100%, but definitely a factor. And one of the things that we do for a lot of patients, and many patients, if we can get them to do it, is put them on a vaginal estrogen treatment. Now, this is not a systemic therapy, so it's not going to help with your hot flashes or mood swings, but it's also, we know that it does not increase risk of breast cancer, stroke, or heart disease. And what it does with consistent use is it can restore the normal healthy tissue of the vaginal area. And we see with time and continued use, improvement in those symptoms that I mentioned. The discomfort with urination, the frequency, the urgency, urinary tract infections. And so we do a lot of counseling on this. It's not a quick discussion, here's a cream, use it, because there's a lot of questions and there's a lot of really good questions. But the good news is that we have so much data and research that shows the safety and the efficacy of using vaginal estrogen. So I think that's a great question and something that so many women have been ignored upon and have told it's just part of normal aging. And, if anyone is sexually active, that is a huge role in discomfort with intercourse and things. So it's a huge quality of life adjustment and improvement if you can bring up that with your doctor, and so much benefit from it. So
Yes, my head is like a bobble doll right now because all the things you're saying are so true. I wish we need to do one just on that. But I want to address this question from Bryn because we haven't talked about surgery much and we are running out of time. I just want to address this as an excellent question. I had a bladder sling in 2007 and I am still pleased with the results. Will that sling ever deteriorate or wear out?
Yeah, so great question. A sling is a treatment that we have for the stress incontinence, so the cough, sneeze, laugh leakage. It's not a treatment for urgency, frequency, or overactive bladder. But slings are our most durable treatment that we have for stress incontinence. We know that it's very safe and we know that it's very effective. Now, there is no lifespan on slings. So there is no time where every sling that was put in 10 or 15 years is going to fail. So if you're still doing well since 2007, there's a good chance that this will last you for many, many, many more years. There are patients who with time, just like anything in life in our bodies, some things do weaken or wear out with time. So there is a potential that you could, need something in the future. We don't know how old you are or anything like that, Bryn, but there is the potential, but as long as it's working, there's no definite time where you're going to need something done. I will say quickly that I have patients who've had slings before and they say, oh, my sling isn't working anymore. And actually their sling is fine, but they just have an overactive bladder now. So we can just, we treat that differently with, again, like the physical therapy, the vaginal estrogen, sometimes bladder control medicines, and we don't have to do the sling because the sling is doing its job and they're doing great with that. So.
Thanks, Doc. A question from Rhonda. How can you reverse fecal incontinence? I wanted to address this because no one's asked a question about that yet.
Yeah, I'll talk about that real quick too. This is a great question, and I'm so happy you brought that up because this can be very distressing, and it often goes along with urinary incontinence, and doctors are horrible about asking patients this question. So we try to go over those issues when we do our first history and intake with patients. But a lot of the stuff that Ann talked about with pelvic floor therapy can address fecal incontinence. Sometimes it has to do with like regulating your bowel habits, like making sure you're not constipated or making sure that you're not having too many loose stools. So maybe adding fiber or like a bowel regimen in order to help regulate the stool. There are various devices, for treatment of fecal incontinence. There are like pessary type inserts where you can actually insert a device into the vagina. It can create an obstruction for the bowel so that you don't have the stool loss. One treatment that I do as a urologist for urinary incontinence, this is called a sacral nerve stimulator. It's an implantable device where we put like a little stimulator along the nerve that goes to the bladder. It's the third sacral nerve. This nerve is the main nerve that's responsible for urinary signals and bladder control. And it's one of like our more advanced treatments that we have for urinary incontinence. It's also approved for fecal incontinence. So once again, a lot of patients have both issues. So one of my big questions, when if we're moving along in the treatment path and we're trying to figure out what to best offer you, if you have fecal incontinence and urinary incontinence, this can be really helpful. And you can also use it if you don't have urinary incontinence and fecal incontinence. So and there are other bigger surgeries like a sphincteroplasty and things like that can be more involved, and that would require workup from a specialist. But it's a great question. So
yes, I'm so sorry I just want to apologize to the audience because there's so many great questions, but this time is moving fast. This is an interesting one. This is from Patty. She says her primary care provider told her that her incontinence issue may be due to her brain and not being able to communicate to her bladder or pelvic region, not because of weak muscles. And is there any comment on this? And can physical therapy be helpful? So I think from both of you, if you have some information on that.
Do you want me to go ahead? Yeah. Well,
yes,
Dr. Bradley has probably more to speak on that. there's probably a lot to that question. I guess I would say, I will say for sure in here, I have people come in with urgency, frequency, leakage, and they are stress incontinence, and they're certain they're weak. But a lot of times their pelvic floor might be working just fine. I would say, particularly with urgency and urgent continence. Sometimes it's just the bladder habits have just been out of whack, and the bladder's been staying in the same patterns for a long time. They're emptying very frequently, and so the brain and the bladder kind of have this thing going on where we're just responding to that. So sometimes the muscles are working fine. We just then need to utilize those at the right time. So we talk about timing, how to use them to suppress the bladder, or with stress incontinence, coughing and sneezing. It's just not, the muscles may not be showing up at the right time. But there are some other neurologic, issues. I do see people with, MS and Parkinson's and things like that. Sometimes their lack of urges and awareness can be a little fuzzy because of those conditions. So we may treat that a little differently, putting people on different schedules for the bladder and bowel, but still trying to get those. Sometimes Dr. Bartley, you can speak to some of that neurology probably better. I'd want them to see Bartley for Dr. Bartley for that, and then come back and see me.
Pass that football.
Yeah.
So I think that everything we do in our body, things initiate from our brain, right? So there's a communication from the brain through the spinal cord to the bladder. And the way I kind of think about it is that the brain and the bladder are not talking. Whether it's a muscle issue, a lot of times it can be, but our bodies don't work on islands. So everything kind of works together. And even if you've got, certainly we'll have patients who have wonderful pelvic floor muscles. They can do the best Kegel in the whole wide world, and they still have incontinence. Mm-hmm. So therefore, it may not be a muscle issue. It may be more of a nerve signaling issue. When the bladder fills, it sends a signal to the brain and says, hey, it's time to go to the bathroom. And you stop what you're doing, you walk to the bathroom, your bladder holds it, and then you release. But sometimes that signal gets messed up. And those can be from nerve issues, things like Ann said, stroke, Parkinson's disease, multiple sclerosis, diabetes, high blood pressure. These can all affect our bladder and our nervous system and the communication there. So if physical therapy is not helpful, then we might want to think about medications or more advanced therapy. And one thing about incontinence is we don't always have to do one thing and then another and then another and another. So a lot of times we think about the whole patient and we try to address everything, whether there's, someone asked a question about foods. So things like caffeine and soda, these can be irritating to the bladder. If you're drinking a lot of water or not enough water, we'll try to address those. And then we might throw in some exercises to help with like the muscle control. And then sometimes we even have to do medications as well. And a lot of times we offer treatments based on patients' goals. And so, this is, again, we said it's not life-threatening. So we know that it's not a cancer that we have to remove tomorrow. But we also know that some patients like to do medications and they'll get a bigger bang from their buck and they don't have the time or the ability to do exercises. I'm not going to make them go. Some women really, and men, they don't want to do medications, and we can do some other things too. So we really try to tailor our treatments based on patients' symptoms, what they come to us with, and what their goals are. So
again, making a list of the things that pertain to you when you go to your primary care provider or your specialist. Thank you for mentioning about the foods, Doc. I wanted to get to that, but the questions keep rolling up. I did want to mention Debbie asked about the correct way to do Kegels, and there has been the link shared in the comments section for everyone to see to Urology Care Foundation to address that actual question. The one thing I wanted to ask is there's one more about pessaries, and I think that's from Nancy. How long can a pessary be used? And could pelvic floor therapy replace having to wear one? And does it help with the bladder or just holding everything? It can hold everything, Nancy. I will say that. And I just wanted to bring that out because a pessary can be used. I have patients who are 90 years old that come in once a month for me to clean, or every 6 weeks for me to clean the pessary and replace it. So I'm jumping ahead, but I do feel a little comfortable talking about pessaries because that's what we do too. So the answer is yes to physical therapy and yes to using pessaries until you are tired of using pessaries. We have 5 minutes left. I cannot believe it. Time just goes so fast. I did want to just giving a shout out to the male listeners in the audience. Now, I know that, clearly Kegels exercises are not necessarily things that are going to help them, but you also mentioned, Dr. Bartley, the other things that can cause incontinence issues in men, such as diabetes, hypertension, and of course, prostate issues. But certainly, do you agree that these are things that they should talk about? I know it's a little embarrassing, uncomfortable, but I think, Larry. Hi, Larry. Women appear to have a bigger issue with this, but I'm a 76-year-old male. What's your advice for the males? I think we saw that right at the beginning of our talk, and I just wanted to just circle back so that we could give Larry the shout out for being the representative for the men today.
Yeah.
Thanks, Larry.
Yeah, and I bet there's a lot more men here
Indeed.
than Larry too. They're just being a little more quiet. So did I answer that real quick?
Please
Okay.
answer that as we went right round up.
I didn't show a slide, but overactive bladder, like it's more common in women as they're younger, but then men actually catch up with women as they age and get, as they get into their 70s and beyond. And so in men, we do think about the prostate, and we think about whether the prostate is causing issues. And sometimes the prostate grows larger, it can create some obstructive issues. And when the bladder has to work harder from an obstruction, it becomes more irritable. Bladders are lazy. They're like teenagers. When you ask them to do more, they become more irritable. So we always think about that. And sometimes we may start you on prostate therapy, whether it's a medication or, even a procedure to open up the prostate. But sometimes it's not the prostate, or even once the prostate is treated, men can have the same issues with like urgency, frequency. One of the big symptoms that men experience is waking up at night to go to the bathroom. And so we'll do a lot of the same thing with men with the pelvic floor therapy, with the bladder control medications. Kegels, I think, can work for men, just as well as women, in those deep breathing techniques. For the stress incontinence, again, that's a little bit more complicated. Mm-hmm. After prostate cancer surgery, we do send a lot of patients for pelvic floor therapy where they can learn to do the Kegels. They weren't taught those when they were younger, like women are. Right. So there's a lot of education there. And then sometimes we are, needing to do more surgical interventions, such as slings or artificial sphincters and things like that. But definitely a lot of options for men. And don't think that just because you're a man that, this is not going to happen to you, or, that nothing can be done with it. So.
Yeah, I think that's the huge message here overall, is that there are solutions and there is hope. So please talk to your physicians, your providers, whomever you see, and seek help so that you can live the quality of life that you have earned all of this time by being a seasoned adult. It is time to wrap up. I'm so sorry and sad to hear that it is, but it is true. Again, I just want to thank you, Dr. Bartley and Ann, for joining us today. We truly appreciate your expertise, and I certainly have taken my own notes to take back to my patients. I know you see plenty of obstetrical and gynecological patients, and we certainly appreciate you. Thank you so much. Thank you to the viewers for being here and for being interested. We have set record numbers over these past 4 weeks, and we thank you for that. Again, you can watch these back on YouTube or AARP of Michigan Facebook page. Special shout out to AARP of Michigan State Director Paula Cunningham for being the brainchild of this. And also, and most especially, to our fabulous production crew headed by Karina Eggleston. We thank you so much. I hope that all of you have a wonderful rest of the week, and certainly have a healthy day, and take care of yourselves.
Thank you. Thanks, everyone.